Okay. I don't have any. I don't have a PowerPoint. For me, it's.
What you wear this thing?
Oh, perfect. Yeah.
Yeah, they can do better with that.
Perfect. I find it's easier if we discuss the concepts without PowerPoint. Although I have PowerPoints created, which I can share with all of you. But in my mind, the objectives for how I envision conversating with you today about my world and how we, the two of us, overlap, your team and my team overlap, is predominantly in acute aortic syndromes. And so for me, acute aortic syndromes encompasses not only the ruptured aneurysm, but also the symptomatic dissections, which my practice has grown significantly with that, and then type B aortic dissections and abdominal aortic aneurysms. Now, I say type B aortic dissections because in the vascular world, we have a relative division of labor in that anything proximal to the left subclavian is in the world of the cardiothoracic surgeons. Anything distal to that is us. I say a relative division because in the acute setting, it's predominantly the CT surgeons, because the whole thought is with a dissection, the consequences of dissection are threefold. We think about rupture, we think about malperfusion, and we think about ischemia. Ischemia in the form of coronary ischemia, okay? And so the way I think about, we'll start with dissections to go first. So how are we going to see dissections? Dissection, the most common risk factor for dissection is hypertension. Family history is significant as well, especially the connective tissue disorders. So hypertension is going to be the most common risk factor. So hypertension causing an intimal injury, so an injury to the innermost layer of the artery. And so in our world, we think about this as where is the injury in relation to the aorta? And if it's before the left subclavian, what we worry about is retrograde propagation of the dissection into either the what's past all of this. So rupture, we think about pericardial tamponade, right? So the intima is disrupted. So now what's happened is that hypertension is propagating into that medial layer, which is presumably a weaker portion of the wall, and now ultimately the worst consequence of that is rupture. Okay. And then ischemia is if that dissection in a retrograde fashion extends into the coronary arteries. So that's why I say a relative division of labor between the CT surgeons and the vascular surgeons. Because now if this is more more chronic, we can support the CT surgeons in, say, doing bypasses to debranch the bigger vessels and then land a stent all the way over here. But that's more in the chronic world. And I have a few examples which I can log in and show you all of what we have done in the past. But in the acute setting, we think more about cardiac tamponade secondary to progression of that dissection into the pericardial space, and then coronary ischemia. Okay. Now, with type B dissections, where we go from the left subclavian distal, now we're thinking about these big vessels, the celiac, the SMA, the renals, and of course all the way down to the legs. So when I say malperfusion, I'm talking about malperfusion in the sense of malperfusion of the gut, secondary to an acute mesenteric ischemia, malperfusion of the kidneys, secondary to dissection extension into the renal arteries, and then the legs. And so I have seen presentations of all of those where we've had to emergently operate. So now you've seen presentation to what's the consequence. Where does this how does this affect you all, and what is our sort of, how can we work together to get the patient taken care of and increase survivability from these problems? Again, with type B aortic dissections, this is where acute aortic syndromes have a common denominator, and that is delta P over delta T, right? So I majored in chemistry, so sorry about that. But I just think about it like that. It's just tension, aortic wall tension. And the biggest thing we want to affect is heart rate. And so this is where you see classically, you want to start a beta blocker first, because if you start an if you start a blood pressure lowering agent, you may have a refractory tachycardia, which could potentially worsen things. So in my mind, I always think about starting a beta blocker first, whether it's in dissections or abdominal aortic aneurysms. Now, I want to make the disclosure that I'm starting with dissections first because our goals of treatment in patients with type B aortic dissection versus AAA vary just a little bit, and the concept of permissive hypotension, which I'll address when we talk about aneurysms. Yeah, I shouldn't say abdominal, I should just say aneurysms, aortic aneurysms, because thoracic aortic aneurysms can rupture as well. So again, when we're thinking about type B aortic dissections, what's happening? So if you all and I were to I have 3 kids, so magic school bus, right? If we were to get on the magic school bus, go through the blood vessels, what would we see? We would see a wet toilet paper, thin layer, just going like this with every beat of the heart. And so if the heart rate and blood pressure are high, that false lumen is going to get more pressurized. So oftentimes when we're looking at a CT scan of a type B aortic dissection, we often are seeing this. This picture shows a few things. This is the true lumen. Sorry, this is the false lumen. And this is a fenestration. Fenestration being a tear. That fenestration becomes extremely important because what's happening is when you have that index injury, more often than not, that index injury is right here. And then it kind of goes like this all the way down. And this is an accurate graphical representation. I try to make it as accurate as possible as how we see. More commonly, what you're going to see is a large false lumen, because that's the weaker part, right? The blood's going to prefer to go where the wall is weaker. So again, if all of us were sitting in the false lumen, we look to our left, we see something just flapping in the wind. That's thin like toilet paper. We look to our right, we see 1.5 layer, the media and the adventitia. If we were to then change seats and go to the true lumen, we would see a flimsy little intimal layer, but on the other side we see all 3 layers. So that's a stronger wall, and so the pressure, the resistance is much lower in the false lumen. So that's why the false lumen is easily pressurized. So again, we're sitting in the magic school bus looking. We see more of a lumen. A larger lumen is the false lumen. The smaller lumen is the true lumen. And then we'll see little micro tears throughout, all the way down throughout. But the most commonly, the largest fenestration or the major fenestration is up here. Again, a lot of this is, I want to be comprehensive so you all can see what you pick up in the field, and then ultimately how do we get to discharge, and what did we do in between, right? And how much what you do in the field or you do in the initial phases prior to us going to the operating room significantly affects what the result is. And oftentimes the results are positive. So again, here you have a patient who has a type B aortic dissection, type B starting just distal to the left subclavian, type B aortic dissection. Oftentimes, because of this concept of delta P over delta T, the major fenestration is here. So now the false lumen is pressurized. False lumen is pressurized because you're seeing weak parts of the aortic wall, so the resistance is much lower. Blood wants to go in that area. Well, how does that manifest as malperfusion? Well, when that flap is just breathing with every heartbeat, sometimes that flap will occlude the lumen. What lumen are we talking about? Celiac artery, superior mesenteric artery, or the aortic bifurcation to the iliac vessels. And so the manifestations would be, and the renal artery, the manifestations will be gut ischemia, mesenteric ischemia, renal ischemia, or lower extremity ischemia. So fresh out of fellowship at the Medical College of Georgia, my first couple months there, and all of a sudden I get an acute aortic syndrome, type B aortic dissection with paresis of the lower extremities and absent pulses. The emergency room did an appropriate workup with a CT scan. Sure enough, had malperfusion to the lower extremities. Here I'm emergently doing an axillobifemoral bypass on this patient. And so that malperfusion is one manifestation of type B aortic dissection. How do we reduce that incidence of malperfusion, rupture, or ischemia? We control the heart rate, which then controls the amount of pressure that the false lumen is seeing, and thereby reducing how much that flap is going to compress the occluded vessel. Okay? All right. Other manifestations of rupture. Unfortunately, I had to take care of a rupture here. 17-year-old postpartum hypertensive emergency. Hypertensive to 210/120. Next blood pressure, 50/20. And what happened? She had, this is where I talked to you about hypertension as a risk factor, but an underlying connective tissue disorder. And remember, postpartum, or rather pregnancy, is a high risk factor for aortic dissection and pathology like that. So she actually ruptured here. And she ruptured here, and she was freely rupturing into her right chest. So we attempted to initially place a stent. So what we ended up doing was I got access in the groin percutaneously, was able to use intravascular ultrasound with my wire to make sure I stayed in the true lumen all the way until I got to here, which I knew I was true lumen because my dissection started here. Initially, when she started to arrest, I initially put a stent here to cover the hole, and then I put a stent here to cover the major fenestration. Unfortunately, the result was not positive. But what this case taught me was the ultimate goal is to treat this major fenestration. If you close the front door to this false lumen, there are going to be little other doors that you can get in. Side door, back door, etc. But if you close that major front door, that'll decrease the false lumen. How does that translate for us? Well, okay, let's say we're not in a rupture setting. We're not in any acute setting, but more this would be more acute setting. Let's say we go to more chronic settings. Chronic setting is predominantly aneurysmal degeneration. Okay? I yell at my son about my poor handwriting, so please excuse him. So aneurysmal degeneration. So what's our goal with the aneurysmal degeneration? Well, what's happened now is you have a weakness in the wall of the artery. So what's going to happen there? Well, it's going to degenerate. So now you're seeing manifestations of this plus this. So our goal again is to occlude to about here. Because what that does, up to the level of the celiac artery. Now you would ask us, well, why don't you just cover the entire segment of where the dissection extends? So some patients come in with dissections that start at the left subclavian, go all the way to the aortic bifurcation. You say, well, we've seen your work. You do fenestrated, complex, physician-modified endografts. Why not do all of that? Well, remember, one of the major blood vessels here is called the artery of Adamkowitz, and that perfuses the spinal cord. So we have to be very careful in how much we cover in a staged fashion. And most of our literature says that if you cover from the left subclavian to about the level of the celiac, you're able to cover most of those fenestrations and really decrease the amount of pressure in the false lumen and thereby decrease the aneurysmal degeneration. Okay? So this is more chronic presentations. Now, this can easily, you see, again, going into that major in chemistry from Emory, that, the back and forth or equilibrium that can happen between acute and chronic, this thoracic aortic aneurysm can manifest as a rupture. So now here we go, right back to acute presentation. And what's our principle with the acute presentation? Delta P over delta T. Reduce the heart rate and thereby reducing the cardiac output and hence the blood pressure and amount of pressure on this. Does all that make sense? As far as time goes, I wanted to spend just a fair amount of time on this. Being at the University of Mississippi is a benefit for us because we have a lot of the advancements in technology. And one of the things I was thinking about as preparing for this is the olden days, it used to be that if you had, 9 out of 10 people who had a ruptured aneurysm didn't make it to the hospital, 9 out of 10 people didn't make it out of the operating room, 9 out of 10 people didn't make it out of the hospital, and then, whatever the remainder is, makes it to a nursing home and not really back home. That's changed drastically to now, instead of a 90% mortality, we're probably closer, depending on whether you had an associated cardiac arrest with your rupture, things like that. You may have a rupture. I had a rupture a couple of weeks ago. He made it home. It's all relative, the degree of rupture, but with the advancements in technology from your end, which is the initial presentation, to our end, which is the additional technology we have to do complex endovascular aortic repair, get access, put a thoracic aortic balloon up to cross-clamp the aorta, to reduce the risk of bleeding while we're getting our stent graft up. Those advancements in technology have really helped us reduce the mortality associated with these ruptures. Okay, but before we move on to aortic aneurysms, I wonder if there are any questions about type E aortic dissections and how we sort of treat those. Because in my mind, aortic syndromes are really dissection and aneurysm, and then both having rupture. Any questions at all?
One thing that comes up, I don't know if you're going to get to it or not, and they may not know right off the bat, is like a penetrating atherosclerotic ulcer.
Yeah,
or something.
perfect. Yep. Yeah.
Does that kind of get managed like a rupture
Yep.
if it
Yep.
starts bleeding?
Yep, exactly. Yeah, exactly. So great question. So I kind of think about those. Good question. So PAU, penetrating atherosclerotic ulcer, or intramural hematoma, and really traumatic injuries, I kind of put them right in the middle because they're kind of in the middle of both. And so a penetrating atherosclerotic ulcer, I think about as the patient who's had a dense atherosclerotic disease, but that ulcer, it's exactly what the word says. It's an atherosclerotic ulcer that's really penetrated into the intima, into the media, and then what happens is it causes a weakness in the intimal layer, and it can manifest either as a dissection or an intramural hematoma. An intramural hematoma is exactly what it says. Now, instead of creating a dissection, you just have blood that's just pooling there. Dr. Mitchell, my division chief, actually had a patient come in, that intramural hematoma ruptured, and he had to take care of that emergently by just putting a stent graft in. So this kind of overlaps these two. The penetrating atherosclerotic ulcer or the IMH can become aneurysmal and manifest as a rupture and aneurysmal degeneration, or it can manifest with rupture, ischemia, or malperfusion. But that's a good point. And again, the same thing. You do the same thing. You really want to just reduce that delta P over delta T, reduce that pressure that aorta is seeing, so that every time it sees that, it's not just propagating that tear, propagating that hole, propagating that bleeding into the medial layer. Does that make sense?
And you said, like for us in transport, we concentrate more on the heart rate initially than the blood pressure.
I think so. Yeah, I think so. I think that, fundamentally how I think about it is, let's say you were to start an antihypertensive, the response I would expect in most patients who don't have their beta receptors blunted would be tachycardia, because what do we notice when our blood pressure drops? Well, you want to increase the heart rate, so thereby if your stroke volume is the same, so you want to increase cardiac output because you're noticing the blood pressure drop. Those peripheral receptors are not seeing what they want to see. And so I always think about blunting the heart rate so that the responsive tachycardia, or what manifests with having antihypertensives, reflexive tachycardia is what I was looking for, won't occur. Okay? Does that make sense?
We recently made a protocol change off the more recent literature review. We're kind of, labetalol was the initial option just because pre-hospital, that's an easy drug to give.
Right.
But, so is esmolol. So we've kind of gone to esmolol, which is more titratable,
Right.
and get that heart rate down.
Exactly.
And then do some kind of antihypertensive.
Exactly.
We still need it. So.
Exactly. Yeah. Esmol, quick onset, easily titratable, and so that's how I think about it. Any other questions about dissections? Oh, perfect. Okay. So when we think about aortic aneurysms, and more often than not, you'll see abdominal aortic aneurysms than thoracic aortic aneurysms, but I think about them the same way. With aortic aneurysms, you want to think about the concept of permissive hypotension, and I think about that a lot, especially when I accept the phone calls from the outside facilities, because what happens is these patients are hypotensive, natural responses, give fluids. Well, if you're ruptured, all you're doing is giving that blood and fluids into the abdomen or into the chest or into the retroperitoneum, and the retroperitoneum can only handle so much. And so then what's going to happen in our world, when we think about abdominal aortic aneurysms, when they have a free rupture into the peritoneum, that's where you'll start to notice the cardiac arrest. Because what's happened is now you're gone from a retroperitoneum, which is kind of more of a fixed space, to now just a free rupture into the abdomen. And now there's all that space for that blood to accumulate, and it's just a gush of blood that comes out. I unfortunately had this two weekends ago at St. Dominic's. And again, the front lines of presentation, resuscitation, etc. was great. Got the patient to the OR. That 9 out of 10, we beat that statistic. Got the patient, got access. She, of course, this was all occluded, so somehow we were able to get a wire through there, put a balloon here, cross-clamp the aorta with just a balloon. Kind of think about the same concept as a Reboa, right? Similar concept as a Reboa, but under fluoroscopic guidance. Inflated the balloon, put a 3-way stopcock, and locked it. Now everybody takes a breath. Anesthesia has some time to, okay, they like that blood pressure. They're kind of getting their blood in because now we have control. So now they can get the blood in to sustain that blood pressure. So when I take the balloon down to introduce my stent graft, we're at 140 to go down to 110, deploy the stent graft. Okay, the big hole is closed. But got the stent graft in, endograft in, opened the belly, decompressive laparotomy to the ICU. Unfortunately, you all know about the lethal triad, right? It's acidosis, hypothermia, and coagulopathy. That was what she succumbed to. So INR greater than 20, hemoglobin of 2, platelets of 30, and with a preoperative cardiac arrest, because she had free rupture into her peritoneum, it was not unexpected. So when we think about, one of the big things that I'm interested in is quality improvement. So with the Vascular Quality Initiative database, which we're involved with and I work closely with, there are calculators. The big calculators for what is the associated mortality, which oftentimes is related to the lethal triad, preoperative cardiac arrest, and where you are going to put your clamp, and how old the patient is, and whatnot. And so when we have a preoperative cardiac arrest, that mortality risk factor goes up pretty significantly higher, to on the order of 80 is close to 100% when there's a preoperative cardiac arrest, because the big things we worry about is just that free rupture into the peritoneum. So what does that mean on your end? On your end, we think about the same concept. Permissive hypotension, we can try the delta P over delta T as long as they're permissive. So here you have a patient with which you think you're transporting for a ruptured aortic aneurysm from another facility. They're talking to you the whole time. Great. I would just leave them alone. Let's not push a bunch of fluids. Let's not push a bunch of medications. Let's as long as they're talking to us, systolic is in the 80s. As long as they're talking to us, that's good for us. Because what we don't want to do is continue to give fluids into the abdomen, into the chest, wherever the point of rupture is, and then that hypotension progresses because now we have free rupture into the peritoneum. So the permissive hypotension is sort of the biggest thing, and this is quite difficult. Because when they show up to us, right, I'm a vascular surgery attending. What does that mean? I have a fellow who's on call with me, and I have a bunch of residents who are on call. In addition to our general surgery residents, we have the emergency room residents and faculty who are supporting us. So by the time we get the phone call, it's like hypotensive AAA, we're going to go to the OR. Great. All I have to do is size. So on your end, this is where it's challenging. But if we go back to the concept of permissive hypotension, keeping them conversating with you, as long as they're conversating with you, mentating fine, and their pressure's in the 80s, I will try to ride that as much as I can. And the goal being to get to the operating room where we can then get percutaneous access, put an aortic balloon up for cross-clamping of the aorta, and then do our definitive repair. Whether it's a stent graft or we get that balloon up, put a three-way stopcock, lock that balloon in place, open the abdomen, and clamp the aorta above the aneurysm to do a definitive open repair. Does that make sense? And I'll tell you, sometimes the anatomy doesn't allow for us to do the complex, physician-modified endograft repairs that we do here on more of an elective setting. When they're ruptured, the goal is to plug that hole as fast as we can and preserve flow to the visceral vessels. The kidneys oftentimes take a hit, but rather be alive on dialysis than the alternative, right? My talk wasn't designed for an hour. More of, in my mind, this is just how I think about it, with some case examples if you guys want some. With respect to the degree of a ruptured aortic aneurysm can manifest in different ways. The retroperitoneum is very helpful in tamponading the rupture. So oftentimes the key for us is where is the aneurysmal degeneration as in relation to the renal arteries. So I'll tell you, since coming to the University of Mississippi about 9 months ago, we've done ruptured aneurysms to here, stent grafts to here, and it kind of manifests like this, where we put a stent graft. We've also done fenestrated endografts, what does that mean? We put a stent graft that then allows us to preserve flow to the kidneys. We were like, well, it's ruptured. You just told me that, the goal is to plug the hole. The hole oftentimes tends to be down here, but if we were just to put a stent graft here, there would still be pressurization here called an endoleak. So we actually extended up to right at about the level of the SMA, and then put some burn some holes in that endograft and put a stent graft there to then have a better seal. And down the line, I think that does better, because what's the natural history of this aneurysm after the stent graft? They develop mural thrombus. Our body resorbs that thrombus, and then that wall just regenerates around that endograft. And a lot of times we'll follow these patients out, and when initially you saw the CT scan go aorta aneurysm with the stent graft to now aorta just aligned with the stent graft. So for us, the big thing, again, I think the advancements of technology have helped the frontline responders as well as us in the operating room, where you have kept them resuscitated, alive enough for us to then get access, put a balloon up if we have to. This fenestrated case, I didn't have to put a balloon up. what we did on this fenestrated case, and I show that as the most sort of furthest example of complex operation used for a ruptured aneurysm, we actually kept him awake the whole time, got access, put the initial stent graft in, and then did our fenestrations. And the reason we do a lot of ruptures, we tend to push the pendulum on keeping them awake, because if you induce general anesthesia, right, you all know better than muscle relaxant, smooth vessel relaxation, vasodilation. Now you've lost your preload. Now you're more inclined to rupture. Mortality goes up with the rupture. So we'll keep them awake. We'll do local anesthesia, lots and lots of local anesthesia, get our access. If we have to put a balloon up, we'll get our balloon up, and then once we have the balloon up, intubate. Now understand that everything is moving very quickly, and I say that because one of the benefits of again, I understand the ivory tower I'm sitting on is because I have all of those resources readily available. I have a team, I have fellows that know how to get access quickly. I'm getting access on this side, you get on access that side. We're both getting access at the same time. So each of us can get a balloon up. One person can get the balloon up, the other person is introducing the stent graft, so we control liver ischemia time. Because hepatic ischemia, although the portal vein provides most of the perfusion, hepatic ischemia is detrimental because that then propagates coagulopathy, right? And that was the case in the lady from a couple weekends ago. She just had such profound hepatic ischemia and unfortunately coagulopathy. That's how I think about acute aortic syndromes for us. And then we could to be comprehensive, beyond all of this. On our end, we talk about when we see the patients and like the next day when they're doing well and able to talk to us, or whenever they are able to talk to us, or when we talk to the family, prevention is huge, right? Risk factors for abdominal aortic aneurysm, risk factors for aortic dissections, risk factors for penetrating aortic ulcers and intramural hematomas, smoking, hypertension, and family history. So smoking, right? Hypertension. The early screenings, right? So 38. I've been a faculty member for 6 years. Been going to the PCP for 6 years because during residency, no one, who has time, right? But that's wrong. Like we should propagate. We do that on our end as faculty to our residents. So why should we not do that for our patients, right? So get PCP access out there, get blood pressure checks, have blood pressure control, and then smoking, very difficult, very difficult. Many of us in vascular surgery devote our lives to smoking cessation. We have the ACT program here at the University of Mississippi. We have it, but the resources may not be very, very much, but if we keep pushing from the front end to refer patients to the ACT program, the university can support them more, seeing all that population going there, right? So smoking, hypertension, and then family history. So this tends to be a male-dominant disease. This tends to be a disease of aortic aneurysms tend to be a disease that's male-dominant, older patients, 65, 70, 75-year-old patients, and then family history, first-degree relative. So if father had an aneurysm, you'd get a screening ultrasound at a young age. If you have an aneurysm, your siblings and your children, I say children, although it is a male-dominant disease, I say children because in Vermont during my fellowship, I had a 49-year-old show up with a 7.9 centimeter aneurysm. And she said, my brothers have aneurysms, my father had an aneurysm, my uncles have had aneurysms. So I knew I needed to get one. I got a screening ultrasound because they were having one in my city. And they found a 7.9 centimeter aneurysm. So we fixed it. But before she left, we said, your children, she's like, I got it. I already set up the appointment, right? So we need to reschedule until the INR is less than 1.8. So, comprehensive approach, right? You all are doing a good job on your end, as evident by the fact that the mortality has significantly reduced. The technology at the university, and I'm not here to promote university. The fact is, tertiary and quaternary care centers have more access to resources, right? We have 2 device reps for each company who are readily available for us, right? So this operation was done with 3 device reps present. And the reason is because I used 1 device rep to do the actual stent graft, another device rep to use the laser to get through that fabric to make the fenestration. So, but that's readily available to me, right? The alternative for this patient would be thoracic aortic balloon, midline laparotomy, clamp the suprarenal aorta or supraceliac aorta, do the aneurysm repair, transfer the clamp to below the kidney arteries, and then the visceral ischemia consequences from that, right? Now where we have a thoracic aortic balloon, stent graft up. Excuse me.
Yeah, go ahead.
Now that we have the technology in the thoracic aortic balloon and the fenestrations, whatnot, that patient was able to leave the hospital 3 days later after a ruptured aortic aneurysm. Where have we heard that before, right? Well, we've never, right? That's a team effort. That is you all on the front lines, the emergency room getting the patient appropriately to the operating room, my team in the operating room responding properly, having benefit of having fellows, and the technology from our division, right? So it's a team effort, and it just starts with this. Now, lastly, trauma. So trauma. Trauma is difficult. A simple answer.
Yeah.
So trauma, it's again that area of the left subclavian. The most common mechanism of action with injury in a trauma is a rapid deceleration injury, right where the ligamentum arteriosum was, just distal to the subclavian artery. So what happens is the aorta is fixed before that, and then after that it's mobile. So rapid deceleration, so the descending thoracic aorta just takes a hit and it gets a tear. So in a traumatic injury, same concepts apply. Delta P over delta T. Same concept. So I say that in the traumatic setting, there have been times when the patient has a traumatic aortic injury, and oftentimes it's a blunt traumatic aortic injury. So I'll use the acronym BTAI. So a blunt traumatic aortic injury can be manifested as there's a grading system. Talk to someone about taking a picture. Don't take a picture of this with my sons because my handwriting is so bad. So there's an intimal injury here. Intimal injury, hematoma, pseudoaneurysm, and then rupture. And those are the grading systems. That's really not what's more important is to think about the progression of disease and understand that most of the time we are going to treat this with surgery. Timing of surgery is variable significantly. Timing of surgery for a rupture obviously is more immediate than if we were to say have a hematoma or a pseudoaneurysm. And a lot of that is relative to what else is going on with the patient. So you see Dr. Denning does a lot of these by luck of draw for her. Is a 34-year-old male who came in with a motor vehicle collision, had blunt type 3 blunt thoracic aortic injury, had a pseudoaneurysm. What's a pseudoaneurysm? It's a contained rupture of the artery. That's all it is. That's what a pseudoaneurysm is. And so the patient was void of any intracranial process. The patient had an intracranial process and that was going on. So we could not do the concepts of delta P over delta T, right? Because in the setting of an intracranial injury, sometimes we have to keep the maps up to promote cerebral perfusion. And so we can't, they're kind of countering each other, right? I want to reduce the pressure in the aorta, but that's going to compromise cerebral perfusion. So we went ahead and repaired the aorta and so that then the blood pressure goals were relieved, or restrictions were relieved. So then you say, well, that's different. You told me blood pressure was in the traumatic injury. It's just a focal defect that we repair and then we're done. It's just a focal injury to the artery that we repair with a stent graft oftentimes, and then it's done. Two other variables. When you repair the aorta in an acute setting, our literature says that about 60% of patients, don't quote me on that, but 60% of patients can do fine with coverage of the left subclavian artery. And so you can cover that because you have enough perfusion from the circle of Willis and whatnot, and you can acutely cover it, but you monitor them closely for any left upper extremity ischemic symptoms or posterior circulation symptoms. And then if you do, then we go back electively and do a carotid subclavian bypass. And so then now what's happening is your stent's over here, and then now you do a carotid subclavian. So it's like going like this and then going here, okay? And so that allows us in the acute setting to, but that's important for you all because then down the line, that you're like, well, I transported you. It's interesting. Now you have an incision here and needle sticks. What's going on? Carotid subclavian bypass. Okay? I think that's everything. Questions?
See if anybody online has
Sir.
questions.
So what are some things that we could do better? And do you see, I know you've had 9 months, as far as patients you get from us or that have been transported by air care specifically, are the things that we could do better, number one? Number two, preferred sites for central access. Do you typically prefer to go right femoral, or are you sticking, you mentioned 2 people accessing at the same time?
Yeah, good question. So that 2 people access was more for arterial access, but you bring up a good point. So, if you have an abdominal, let's say your abdominal aortic aneurysm, right? So, upper extremity access would be more preferable than the lower extremity because otherwise it's, upper extremity or lower extremity is equivalent because it's an abdominal aortic process, not necessarily a venous process. But in the setting of a trauma, that's when I think more about being more specific on site of access, because a traumatic injury, whether it's the aorta or the vena cava, a sort of a transabdominal gunshot wound with concern for vascular injury, I think more of upper extremity than lower extremity, because let's say you do have an iliac vein injury or an IVC injury, then you're essentially going to infuse everything into the abdomen. So to your question about access, I think in my world of dissection or really acute aortic syndromes, the access is more nice, big, access, multiple access. Because then when we go to the OR, if we have, when I say nice, I mean they work, they're big for massive transfusion, and they're in a site where it's not more central. That's helpful because then when we are doing our work, we don't have to wait for our anesthesia team to get more access.
So would your preference? So we can do central lines and arterial lines, and we do have ultrasound capability. So would your preference be? I guess I should have specified. I didn't ask it well. Us not to access femorally.
I think that's a difficult question for me to answer, and the reason is because I don't know what your limitations are with respect. You can do one thing, but something that's moving, and if you're more facile, putting an antecubital IV that's large bore, that would be readily, as opposed to a central line that. If you put a central line in, a lot of times in our world with CLABs, catheter associated and whatnot, if it's going to be in the groin, we may have to take it out to put our large bore sheaths in to deploy our stents. We don't want that stent to get infected, so here we have something put in the field. No criticism, but we don't know what the sterility was, right? And so I think I would rather prefer some peripheral access for our anesthesia team to readily have access, as opposed to now there are wires and things going on. But you have to do the best you can, because your job is to have access to try to keep this patient alive in order for us to then take care. But again, if it was my preference, I would say something in the upper extremities that then maintains sterility, but also when we are working here, it's not something we're going to have to remove or kind of fish tubing up to our anesthesia team. What can you do better? Again, the disclaimer, I've been here 9 months, but I think the principles of blood pressure management in the sometimes it's difficult. You don't know, is it a dissection? You don't know if it's an aneurysm. Sometimes it's sepsis with a history of an aneurysm, so you think it's a rupture. It's actually sepsis secondary to UTI, whatnot. I think if you truly have a diagnosis of acute aortic syndrome, I think using that principle of delta P over delta T and in dissections, penetrating aortic ulcers, intramural hematoma, versus and in the setting of a rupture, thinking about permissive hypotension. So you have a patient that has a rupture. A lot of times that patient I described to you with the fenestrated repair, I was like, Mr. So-and-so, you okay? Yes. Are you feeling this? No. Okay, yes. We'll give you some more numbing medication. So he was conversating with me and our anesthesia team the whole time we were repairing. Permissive hypotension. He was still in the 80s and 90s. Once I put that stent in, boom, blood pressure went up, because now there's not a free hold and it's just bleeding through. Does that make sense? So I think that answers your two questions about what you can do better. I can't tell you. Maybe in a year but please understand that poor outcomes are not related to one factor. This is a devastating process. A rupture is I have on my phone a QX calculator, a VQI risk calculator that I use when I go and speak with the family. Suprarenal clamp, age greater than 75, preoperative cardiac arrest, and two other variables. Check, 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 check. 80% mortality. Now, whether that 80% mortality is after I get them out of the OR in the ICU, or even before I get them, after I get them out of the ER to the OR, I don't know. I'll give you the example of the patient who I took care of a couple weekends ago. Greater than 75, suprarenal clamp. She had she had chronic kidney disease. In the ER was doing fine, but intubated. Made it on the operating table and arrested. In my mind, that tells me two things: ACLS, and then she ruptured into the peritoneum. Mortality went from 60 to greater than 80%. So already a high mortality. Now significantly higher, right? So when she got to the ICU and then succumbed to the lethal triad with her coagulopathy, hypothermia, and acidosis, the family was that helped me. Now, was it that there wasn't proper transport? No. And I'll be honest with you. Oftentimes, a lot of times when I am in this, I don't hear about the transport, whatnot. It's our ER colleagues who hear about the transport. But for us, I think sitting on the ivory tower and telling everybody to come to us is a bit difficult, right? Because I'm saying you have an aneurysm, I want you to drive 3 hours one way to come see me so that I can watch it. It's difficult for patients. They have to arrange transport, they have to arrange people to take care of the family. But the reason I explained to them that why we need to do it is because at tertiary quaternary care centers, we're able to do complex repairs of aneurysms for the people of Mississippi without having to send them to Nashville, Shreveport, New Orleans, Birmingham, Texas, etc., which is further. And they may not necessarily have the support. So I think the benefit of University of Mississippi is that we're the quaternary care center here. We have the resources available and the technology available to do some advanced work to support these patients. But I would just say I hate to ask everybody to drive for so long, but I do think there's a significant benefit because some patients would have gotten a large midline abdominal incision, 6-7 hour operation, 7-10 days in the hospital, maybe home, maybe nursing facility, maybe rehab facility. The alternative, and I've watched my mentors do this, needle sticks, small incision in the arm, home in 3 days, back to relative normalcy of life in 3 to 4 weeks. So that minimally invasive approach and more now, that's from having the technology and resources available at major institutions. Did I answer? There were 4 questions. Okay, perfect. Yeah. Questions? It's a very difficult process. And again, it's hard for us to quantify. I didn't want to do PowerPoint intentionally because this is more interactive, but the Rutherford's Textbook of Vascular Surgery has a nice table from 1999 to 2015, I think, that shows the mortality rate associated with ruptured aneurysms. And what that really depicts well, it divides it between males and females. It depicts a downward trend in the mortality associated with ruptured aneurysm, but it persists to show that it's a male-dominant disease. And so, again, the smoking history, family history, and history of really hypertension and the cardiac disease risk factors are so important. So now, even as you transport the patients to us, that's the acute setting. Now, when they're leaving, and say you have the benefit of seeing them again, well, you had a ruptured aneurysm. Okay, well, sounds like you're not going to smoke again. Sounds like you're going to go talk to your family members about that, especially the male family members, about getting screened, right, the first-degree relatives. And it sounds like you're going to take your blood pressure medications because you got a second chance at life, right? Very good. Thank you very much.